right, good morning and welcome to the third of our four-part series of Facebook Live events focused on women's health information. Today I am joined by Tracy Weeber, who's one of the nurses here in our Nettleton Mother-Baby Care Center. She is our Women's Services Program Manager. And Dr. Raleigh Unterseher, who is one of the OBGYNs on Enloe's medical staff. So welcome. Thank you guys both for being here today.
Good to be here. I was already here this morning, but...
I know. So for our audience, Dr. Unterseher is already well into his day. He had a baby call this morning at about 4 a.m. So we've got a new little one here with us today. Not with us, but here in the hospital, and lots of experience to draw on. So with that, our topic today, very relevant to that, is Going the Full 40. So Going the Full 40 is actually a public health campaign that came from the Association of Women's Health Obstetric and Neonatal Nursing. And it's all about encouraging women to be patient and go the full recommended 40 weeks of gestation for the best outcomes and best health and best start for their babies. So Tracy, can you tell us a little bit about what is Going the Full 40?
Well, we tend to think in OB of pregnancy as 40 weeks. So from your first day of your last menstrual period to the time that we want you to deliver, if you have a normal healthy pregnancy, is 40 weeks. So in layman's terms, we talk about 9 months. And so it throws people off a little bit when they come in and we say, oh, you're only 12 weeks.
They're like, wait a minute.
But how that relates to the campaign is that when you ask women, how long should you be pregnant? A lot of people really felt like that babies, that if you were within a month or so of your due date, that it was fine to have your baby a little bit early. And what we now know is if you can wait the full 40 weeks, there are health benefits for mom and baby.
Right. It's really important, and it's hard because as we get farther and farther along, we get a little bit anxious. We're excited to meet that little one, but there are really important health reasons to be patient.
Yes.
Before we continue, I just want to remind our audience that we are going to be monitoring our Facebook Live today. We are going to be watching for your comments, your questions. So please feel free to chime in, and that way we can ask our experts here today to provide some answers for you and have a nice little dialogue. So, Dr. Unterseher, so Tracy, told us that the goal is to go the full 40 weeks. Can you tell us some of the reasons why that's important?
Well, we talk about weeks, and Tracy touched on the months issue, and the biggest reason we, as obstetricians and pregnancy care providers, like to talk about weeks is because of the precision. For example, what 9 months are you talking about? If your pregnancy is 9 months, from January to September, 9 months would only be 273 days. If you went from April to December, then that would be 275 days. And so we want the precision of weeks because, as we'll discuss a little bit, weeks count. Right. Months, there's too much can happen within a month. And so we want to know 37 weeks, 38 weeks, 39 weeks, 40 weeks for what advice we give and when we do things and when we don't do things, when we sit back and wait.
Yeah, which can be the exciting part, is the waiting and seeing, and baby's doing a lot of growing and developing with each of those weeks, as you mentioned. So what are some of the concerns for mom and for baby? We have a question. So the question is all about what are the implications of high risk, and do we still encourage women to go the full 40 weeks? I think we'll be talking about that a little bit more as we continue with today's discussion. So hold on to that thought because we'll be getting there. But for a normal non-high risk pregnancy, what are some of the concerns for moms and babies if a woman doesn't make it to that full 40 weeks?
Well, we traditionally say your full term once you reach 37 weeks.
Okay.
But now with the study, there's a difference between 37 to 38 weeks, 38 to 39 weeks, so forth, so on. Now we refer to the 37 and 38 weeks as early term, 39 to the 41st week as term, and then late term, and then post-term, because of what's happening during each one of those weeks and what our response should be and how we should manage. The sweet spot for the obstetrician is 39 to 40 weeks. It's okay to go past your due date, but of course that centers on 40 weeks. So, we give ourselves a little wiggle room because, we're not on call all the time. Weekends do happen, holidays happen, but
Babies
our
have their
goal
own
is
agenda.
that if a mom can just go into labor between that 39th and 41st week, that's ideal, that we hit the sweet spot.
Right.
So some of the things that we might see if a woman doesn't go to the full 40 weeks, for her baby, the baby may experience problems with regulating its own blood sugar. It may not be as good of a breastfeeder, may have more jaundice or yellowing of the skin that requires some treatment, and there may be separation between the mom and the baby if we have to treat the baby for these things. And our goal, not just here at the Nelton Mother Baby Care Center, but nationally, is to have that first golden hour of skin to skin so the baby and mom can kind of get to know each other and the baby starts to breastfeed or attempts to, because that really gives them such a good start. If you watch the first Facebook live event with us with Heidi Cantrell, she touched upon some of the reasons why that early breastfeeding is so important for longevity and exclusivity.
That's a really good point, and we want to make sure that the baby's strong enough to have that bonding experience. Thank you. So, risk factors. We had a question about, what if a woman has a high risk pregnancy, and are there things that women can do to lower some of the risks associated with pregnancy and try to reach that optimal 39-40 weeks?
Well, preventing preterm birth is a dilemma because we don't have completely effective strategies. But if we can focus on overall health and reducing risky behavior, poor diet, excessive weight gain, not being careful physically and putting yourself in harm's way. Maybe you love horses and get tossed from your horse, or you like to jet ski, but putting yourself protecting yourself against high speed, high velocity, high impact activity, that would make sense to do. A good healthy diet optimizes your immune system so you can fight off infection. Infection at any point in pregnancy certainly puts you at higher risk for rupturing your membranes or going into labor early. So those are some of the things that you could do.
And if there are other things that would put a woman in that high risk category, the question specifically that we got from Stephanie says that someone who is considered high risk it's been recommended to her, shouldn't go past 38 weeks. So are there situations where maybe we don't recommend going the full 40?
Well, like we said, the sweet spot for the obstetrician is the 39th to the 40th week, or the week after, up to 41 weeks. But yes, there are maternal, fetal, and even uterine conditions where the sweet spot is moved up a little bit. So high risk would define all these things. Specifically, if a woman's uterus had a scar on it from a previous fibroid surgery where there was a deep cut into her uterus, that uterus is weakened, and going into labor could potentially result in the uterus rupturing. And so getting there and doing a C-section prior to the onset of labor is a safer thing for mom and baby for the rupture, but we want baby to be as mature as possible, so then the debate is the sweet spot for this mother and baby actually 38 weeks or 37 weeks, and it varies individually on what surgery she had. Likewise, if there was a placenta previa where we did not want her going into labor and disrupting the placenta, potentially compromising baby's health, yeah, it may be earlier. It may be 36 weeks. It may be 37 weeks. If the mom comes in with ruptured membranes, that doesn't provide the optimal environment inside the uterus for baby. So we may say, well, it's better that we get the baby out now, either by C-section or by inducement or what have you, whatever is indicated, just for baby's health and preventing infection. Sometimes the babies don't produce enough fluid in there, just low fluid, even though she maybe not have ruptured her membranes, that would not protect the umbilical cord, and the baby would have a higher chance of having compression of their cord or passing meconium into the fluid, and if the baby's not growing appropriately, it's just not as tough to handle the rigors of labor, or we want to get this process started before the baby is weakened to a point to not tolerate labor. So sometimes we will choose to then say, okay, the sweet spot is a little bit earlier.
The most common things high-risk conditions we see in pregnancy are either related to preeclampsia or high blood pressure during pregnancy, or diabetes. Gestational, meaning you just develop it during pregnancy, or you may have it already pre-existing. And whether you're diet controlled or you need to take insulin really plays a factor in how individualized your care is and when your delivery would be anticipated or when we might want to deliver you. If your diabetes is not well controlled, it could result in an extremely large baby. Or if you're on the other spectrum, if you have really high blood pressure and there's risk to continuing the pregnancy for you because you could end up having a seizure or a stroke, your physician may recommend that we bring you in and deliver you a little bit earlier. And it's not always a C-section. Sometimes it's what we call an induction, where the physician would do cervical ripening, so that's to make your cervix soft and pliable, so that when you start contracting, maybe with something called oxytocin, that the bottom of your uterus will open up your cervix and allow the baby to come out from below. So the key to a healthy pregnancy and avoiding preterm labor, I would say, would be seeing your provider regularly, having your risk assessed, coming up with a mutually agreeable plan with your physician or your healthcare provider about how your pregnancy should be managed. We can get nutritional consults. There are all sorts of referrals that we can make to help you modify your lifestyle so that you have a better potential for you and your baby.
Yeah, I'm glad you said that, because as Dr. Unterseher was talking, I was thinking this is the perfect reason to encourage that constant dialogue, conversation with your healthcare provider, because there are so many factors that can go into a pregnancy and healthy one, if there's challenges, and having that good open conversation sometimes might not be easy, but it's so super important. So we've talked about the early side, but sometimes, especially with first babies, women might go a little bit longer than 40 weeks. And I remember when I was pregnant, I was like, oh boy, baby's growing and 40 weeks has come and gone. And, you know, is it best to just take a deep breath and be patient and let baby pick his or her own birthday?
And, you know, you bring up a really good point. One of the campaign slogans for going the full 40 is let your baby choose its own birthday. And if everything's going well in your pregnancy, even though we all know when you get toward 40 weeks, you dream about the day you can deliver. All the aches and pains in pregnancy, your tiredness, if you still have nausea and vomiting, just all those things can make you feel like, I just wish I could get this over with now. But there's such great benefit to your baby and to yourself for waiting. When your body prepares itself for labor, you usually have an easier time of it. And you actually reduce your risk for C-section if you allow your body and your baby to choose when birth is going to happen. In terms of going over, I think that's most everybody's nightmare in terms of how you feel, because you're tired and you just want to get it over with. But they're really, from 40 to 41 weeks, there's only a slight increase in risk, and your doctor will monitor you very closely. We bring you in for what's called antepartum testing, and so you'll get a non-stress test where we put the fetal monitor on and we look at your baby, and we can tell if your baby is well oxygenated. And if it is, then you may decide not to deliver that day, but wait a little bit longer and give your body a chance to try to go into labor. But certainly when you start passing 41 weeks and you're getting toward the 42nd week, the concern is that your placenta is post-mature. That means it's now starting to get some calcifications and little areas where it decreases the oxygenation to your baby. And so we would want to bring you in and try to do things that will help you jumpstart you into labor. Because after 42 weeks, then it becomes very worrisome.
To give some specifics on that, if a patient of mine that is doing well and we have good dates, so I know that her due date or her 40 week is secure, and we get to 41 weeks, I at least need to know that the baby has adequate fluid around for protecting the umbilical cord. That's a good sign of function and health. The baby's active and moving, and like Tracy said, the monitor strip shows a reassuring heart rate tracing. But what's the cervix? The cervix has a process of going from ripe or ready to active labor and being ready. And sometimes at 41 weeks the cervix isn't dilated and it's not thinned out or effaced. And so we may start by ripening the cervix. That may take days. It doesn't happen in an instant. And so sometimes there's a process that doesn't mean, oh, you're 41 weeks, come in and have a baby. Or at 42 weeks, we may start a process that doesn't have a baby for several days.
So you may actually come into the hospital for cervical ripening, and there are many ways to accomplish that, but it doesn't mean that today you're having your baby. It's only if your body is ready that it reacts positively to the things that we're trying, and you go into labor, then you could deliver. Otherwise, we may send you home to come try another day, and frequently women will go into labor all by themselves in between those periods of time that we're doing cervical ripening, which was the best of all worlds.
So patience, that seems like that's the key. So we do have another question here. So Christina joined us, and she wants to know, Dr. Unterseher, what are your thoughts on silent C-sections?
Well, if that's the mom's preference, certainly we can accommodate that goal to the best of our ability. Safe surgery involves communication.
What is a silent C-section? I haven't heard that term, and maybe some others in our audience haven't
So
either.
my understanding of a silent C-section is they're talking about sound and keeping conversation, noise, sounds to a minimum.
Okay.
And we're happy to accommodate that to the best of our ability, but there are times when instruction needs to be given for baby and mom safety.
Right.
So it's always with the understanding we'll do the best that we can, but to be completely silenced takes away one tool for us to be safe.
Right, the communication again.
Yeah, so we can't guarantee a silent C-section, but we can sure keep it as quiet as possible.
Mm-hmm. All right. Let's see. We have another comment. She says it was so hard to be patient, but she's so thankful for it. So yes, that's a great message. That's exactly what we want to hear. So thank you for that comment, and thanks for joining us this morning. So we talked about the going over the 40 weeks, and you did share some of the concerns. Are there any other things that women should think about, or just be reminded of, as far as if baby is taking his or her time in wanting to come and show their pretty little face?
I think that in this campaign, they give you some fun reasons why you might want to wait. It's your last moment as a couple before you have a baby.
If it's your first baby.
If it's your first baby. So you don't have to hire a babysitter to go on a date. You can use your belly to prop your meal on, or your iPad. It's a good excuse to get foot massages from your spouse or your partner. Good time to get a pedicure, because at this point you're probably not able to reach your feet.
You might not even be able to see them. So
Many women are off work at this time, so it's an opportunity for you to kind of center yourself, make a space for the baby in your life, get your home ready, and relax as much as possible, because as bad as sleep is toward the end of your pregnancy, having a new baby, there is a distinct lack of sleep. So this may be your last opportunity to nap in 18 years.
that's a very long time. So one of the things, so we've talked about the importance of going the full 40 weeks. We've talked about the possibility of going under, but some reasons why maybe women can't. And I think it's an important reminder that not everybody is going to. So there's no While we want to encourage that, and we want to encourage the patients and letting the baby dictate when the birthday is going to be, sometimes it's just not possible. And so if things come up, like you talked about, the high blood pressure, the diabetes, some of the anatomical issues,
uterine and placental issues,
right?
Sure.
Then what kinds of things might women prepare themselves for? So C-sections, is that inevitable? Might they deliver naturally earlier? And what should they expect? How can we lessen those concerns?
We certainly wouldn't start prenatal care saying a C-section is inevitable, but we've seen a dramatic rise in C-section from when I was a resident and started as an attending, to the point where we reached 1 in 3 babies born in the United States being by C-section, without an improvement in outcome for babies or moms. And now with the understanding of that high volume of women having had C-sections, some of the problems that can occur from having 1, 2, and more C-sections. So we want to find the right C-section rate, which no one has been able to define. When I was working for an HMO back in Southern California, they had decided that the right number was 15%, and if I was over that, I would be called in to the medical director, and we would talk about my rate. I would want to talk about the individual patients. And so there's always a problem with rates, because it always comes down to the individual doctor and the patient that they're taking care of, and whether for that mom and that baby, the C-section is in fact the best thing, because it's a fabulous tool that saves lives of mothers and saves lives of babies. We just want to use it at the right time.
I'd like to boast for a minute about Enloe Medical Center. We were recently recognized by the state of California for being on the honor roll for having a low primary C-section rate. And the reason why this is important is women who have a first baby by cesarean section, they're most likely going to follow on the path of continued cesarean sections. Whereas if a first-time mom has a vaginal birth, then she's much more likely to continue in that pathway. And as Dr. Unterseher alluded to, if everything is going well medically and obstetrically, and your labor is going normally, then C-section isn't something we're really looking at until problems arise. And we really want to give you the labor support, so our nurses are specially trained to be able to do that. We are patient in waiting for things to get rolling and how long it might take. And we are part of the California Maternal Quality Care Collaborative, looking at how we can safely reduce C-sections, because everybody recognizes that we kind of overshot the mark as a nation, and we're kind of finding our midpoint now. So we're very happy that we were recognized, and we have a fantastic group of providers and nurses that will make this possible for you.
That's a good thing. And we have an amazing team. So we do have another question here from Christina, since we're talking about C-sections. Her question is about C-section. She says she's asking about them because it's her second and last baby. She is getting her tubes tied and would like to have a C-section and the tubes tied at the same time. So is that reasonable? Is that a good course of action?
It's very reasonable, and it saves her another surgery if she's sure, and instead of having to go back in 3 months or 6 months or a year to have it all done, have one recovery, one anesthetic, and not have to buy birth control pills, buy NuvaRings, have Nexplanons put in their arm, or have an IUD placed.
Right.
Yeah, so it's a very good thing. Our concern as a provider is that, are you really sure? Because we can't unring that bell very well, especially nowadays when we remove the entire tube instead of just ligating the tube for future risk reduction of cancer.
And ligating just means cutting.
Sorry, jargon. Jargon word.
Okay, so thank you for that. Let's see. Oh.
More questions?
No, she says, yes, I'm sure. Okay, so another thing that we've kind of mentioned just in some of your responses is induction. So what is involved in that if we're trying to help the woman deliver naturally instead of going the C-section route, and what can they expect if they encounter that?
Well, the word induction means we're doing something either by medicine or mechanical means to start the cervix opening and the uterus to contract. Oxytocin, of course, has a bad connotation because oxytocin, hard contractions, lots of pain, and a long time. Well, nobody wants that, but that is our best tool that we're using right now.
And so in induction, what would happen is your provider would talk to you in the office prior to the time that you were scheduled, and you would pick a date that was safe for you and your baby, and they'd make an appointment here at the hospital for you. We usually bring you in extraordinarily early in the morning. So
4 a.m.
people don't like that so much. Because we may be doing a couple of inductions, and we want to make sure to get everybody rocking and rolling by the afternoon if possible. So when you come into the hospital, you come up to the mother-baby care unit, and when you get to us, if it's an oxytocin induction, then you'll get an IV, so an intravenous line, and we'll put you on the fetal monitors, make sure that your baby is okay and that you're starting to contract. And then we would really encourage you to walk around, to do things that make you feel most comfortable, because an induction can take quite a long time. For a first-time mom, for moms that have had kids before, it could go a little bit more rapidly, at least we hope. But we don't want you to sit in bed doing nothing. We want you to be actively moving around, encouraging your labor, and taking positions of comfort.
So for women, I've heard over the years, there's all these little wives' tales of eat this certain food or do this certain thing to induce your baby and induce your labor. Any comments on that?
I have yet to find the cookie or the tea that really works.
And don't use castor oil.
Well, that works, but
Well,
not
you
for
will
babies.
also have
But
diarrhea,
not for babies coming out.
which is not a good mix in childbirth.
No, that sounds terrible.
Something will be delivered.
But it is okay to eat when you're in early labor, and because it's just like running a marathon. You carb load, and the day of the event, you want to feed your body the fuel, so we keep you well hydrated, meaning drinking lots of water, and we also give you light foods that make you feel good and that you can tolerate, because as much as we wish labors were 1 or 2 hours, that's not the reality for most women. Labors can last 12, 24, sometimes a little more, because there's phases of labor, and the first part is actually very slow. The time to get from 0 to 6 centimeters can take days. It's the fast part from 6 centimeters until you're open approximately 10 centimeters and the baby can move its way out that moves more rapidly.
So fuel up, gentle exercise.
And be patient.
Here comes baby. Be patient.
Be patient.
That's our motto for
You
today.
came to the
Be
hospital
patient.
and you have to be sent home, it's okay.
It is, if that's what's best for our mom and baby. So we had a follow-up comment. I had asked you about the silent C-section earlier, and she's correct. It's actually a gentle C-section. So are you familiar with that term?
I think she may be referring to, and I'm not exactly positive, so we'll wait for your comment in response to me.
Yeah, we're watching, Christina.
What we're trying to do is when the baby is born, via C-section, to keep mom and baby together. So once the cord is cut, and sometimes even before the cord is cut, the baby can go up to mom. So there's no separation if the baby is breathing fine and doing okay. And that initial skin to skin can be very helpful for mom and baby to kind of get ready for breastfeeding and just initial bonding. Some babies after a C-section may not be able to go directly to mom, but we will bring them back to mom as soon as they're stabilized. So that may be part of what you're asking, but please comment and we'll answer whatever we can.
We're getting lots of good information, even with the terminology.
as a surgeon doing the C-section, if we have the opportunity to be a little bit slow on clamping and cutting the cord at C-section, we will do that. But if mom's losing blood rapidly, then we don't have the choice and we have to be a little quicker. But we respond to the situation that's in front of us, and keeping in mind the goal of health of mother, health of baby, doing the best we can for both.
And I think what Dr. Unterseher was referring to about cutting the cord, there's something called delayed cord clamping that we do practice, and that allows the cord, while it's pulsating, to still feed blood to the baby, and once it stops pulsating, then separating the two. And we do try to wait. There is benefit for the baby, even premature babies. So if that's something that's done routinely whenever possible.
Thank you. And Dr. Unterseher, we had another comment here I thought you would appreciate.
Okay.
So Carrie says that she had her daughter here and you were her physician.
Okay.
And she says throughout the pregnancy you were her doctor through the pregnancy and delivery, and it was a great experience and she couldn't have had a better doctor. So
well, thank you,
way
Carrie.
to go. So towards the end of pregnancy, women are getting tired, and they might have a few extra little aches and pains and discomfort, and they're excited to see their baby. So is there anything that can be done, either that we as healthcare providers can do to help lessen that discomfort and make those last few days or week a little more bearable?
Well, I'm a big believer and fan in massage therapy.
I am too. Me too.
I think it's important for every OB provider to have some business cards of some of our excellent local providers, so it can help alleviate those pains. It works. It doesn't work forever, and that's why they have to repeat business is built in, because it does take more than one, but it's an excellent way of relieving some of that muscle tension and stress and back pain. It's universal, but it can't be helped.
Other things you can do is if gentle exercise a lot of times does relieve some of those aches and pains. So walking, even swimming can be useful. There's yoga and Pilates that are specially designed for pregnant women. And
we posted the link last week, so
yes.
if you're looking for a resource, go back and find that.
But also just cutting yourself some slack. It is, at the end of pregnancy, you do start to feel like you're done. And so being able to talk to somebody, your provider's a good person, your girlfriends, your mom, your aunts, the wise women in your life may have special things that they did to help relieve the aches and pains, and listen to them. But most of all, cherish those moments, because most people aren't having 10 and 12 babies, and so the 1 or 2 babies that you are having, that may be the last time you're pregnant.
So enjoy it. So we're coming to the end of our conversation today. There's been a lot of great information, a lot of great questions, so thank you to everybody who's been chiming in. But before we do wrap up, is there anything else that either of you would like to share with our audience on the topic of going the full 40?
It's a great goal. Sometimes we can't reach that goal, and you have to give yourself a break. If the doctor says you're 36 weeks, we need to deliver the baby. We're 37 weeks, you need to deliver the baby. You do the best you can. For each pregnancy, each mom, each baby, there is the sweet spot. I'm not talking about diabetes. But, there is the optimal time for the best outcome. And sometimes it's not the full 40. But we don't want to be arbitrary in our intervention. We want to have a good reason, and we want to have evidence that yes, this is the best time, other than I'm done, I've had it.
I like this date for baby's birthday. Let baby decide.
Okay.
I think remembering, like Dr. Unterseher was discussing, that the goal is to have a healthy baby. So the individualized plan that you have with your provider, that's the one that's right for you. We're encouraging going the full 40 for women that don't have any issues going on. But if you have to adjust your plan a little bit, realize it's usually because we're asking you to consider it for the interests of yourself or your baby.
All right, well thank you both for that. And just double checking, I don't think we have any extra comments. So I want to thank you both for being here and sharing all this really great information, all the encouragement for the women who are out there having babies and will be coming to see us. And I want to encourage all of you. We've got one more Facebook Live session on mom topics coming up next Thursday. We'll be starting again at 11 a.m. And next week we have something really fun and different. We're going to be talking about how baby wearing can help support baby bonding and showing you some creative ways to do that. So I hope that you join us next week. And thank you, Tracy and Dr. Unterseher. And have a great day, everybody.